Morning, everyone. A warm welcome to all the dignitaries and participants joining us from all across the country. I'm Dr. Shilpi Sharma, working as Project Scientist C in ICMR Bioethics Unit, and I'll be moderating the sessions for today's program. It is indeed a great pleasure to welcome you all for a public webinar on ethics, compassion, and dignity in end-of-life care and death. And I'm very grateful to all of you for taking time off from your busy schedule to attend this program. With this background, I would like to invite Dr. Prashant Mathur, Director, National Center for Disease Informatics and Research, Bengaluru, to give welcome remarks for the program. We welcome you, sir, and over to you.
Thank you, and a very good morning to everybody. Thank you for being here with us on a very important public webinar that we are organizing around ethics, compassion, dignity in end-of-life care and death. This is part of the celebrations of the 75th year of independence of India, the Azadi Ka Amrit Mahotsav, and ICMR's efforts in health research and its related fields. This public webinar has been organized to present what the ICMR Bioethics Unit has done around this topic. So we had the end-of-life care definitions and later on brought out the guidelines for do not attempt resuscitation. Today, we are joined by an eminent panel of experts who will cover different aspects of this topic and provide you a deep insight to create better awareness in providing a dignified death. With this, I would also like to welcome Dr. Vasudha Muthuswamy. She is the chairperson of our ethics committee and the Central Ethics Committee of ICMR, a trained medical graduate and postgraduate in obstetrics. She was the founder of the modern bioethics that we see in ICMR, who superannuated from the ICMR headquarters, has been a senior colleague, a mentor and guide to many of us. And many of the contributions of bioethics that we see in the country have been under her blessings and guidance. As president of the Forum of Ethics Review Committees in India and the founder secretary and steering committee member of Forum of Ethics Review Committees in Asia Pacific, she has not only done a lot in India, but has taken this across the boundaries of the country. As I said, she has been steering a lot of efforts, including the ICMR Bioethics Guidelines of 2017, the Stem Cell Research Guidelines, GM Food Safety Evaluation, GCLP, and animal experimentation. She has trained over several hundred ethics committee members, have evaluated many ethics committees, has given several orations, and is bestowed with publications and awards. More than this, it is her humbleness and contribution to the area of bioethics, which has been a stellar performance. May I welcome you, madam, to this public webinar and request you to take us through the other eminent panel of experts that we have and in the conduct of this webinar. And I hope that all participants, we will be live streaming this on YouTube as well. All participants will benefit from this. Please put in your questions and comments related to this. We will try to accommodate as much as possible during this time so that our panel of experts respond and clarify your questions and comments. Thank you. And over to you, Dr. Muthuswamy.
Thank you, Dr. Prashant Mathur, for this introduction, and thank you, Shilpi, for moderating this program. Today's public webinar is, as introduced by Dr. Mathur, is an area of personal interest to all of us, whether we are physicians, patients, or relatives who have been dealing with the terminally ill patients in our life. It's a personal topic of interest which has great interest to everybody. We face instances in life where our loved ones are at a critical situation, where any treatment becomes futile and their life is getting prolonged. We desire to make their life comfortable as much as possible so that the end can come with dignity. We have illustrious speakers today who are going to give us a glimpse of what is palliative care in such situation and in different settings. As I introduce the speakers, you will realize that the speakers are from the different aspects of life, in at what different aspect we are handling with this kind of situations. And in each such an environment, what is an acceptable method or procedures which can be adopted for the same, so that our loved ones are comfortable till the end of their life, and then their death comes with a kind of a dignity. So it's my pleasure. I have been given the pleasant duty to introduce the speakers of the day. In the beginning itself, I'm going to introduce all the speakers so that there is no interruption in between, and all of them can take up the topic one after the other. The brief biodata of all the speakers are projected. I'm not going to, for the sparsity of the time with us, I'm not going to read out everything. You can see it yourself, but I'm going to just give a gist of their achievements. Now, the first speaker of the go is going to be Dr. Roli Mathur. As you heard from Dr. Prashant Mathur, ICMR has been working in this area of end-of-life care for the last few years. We have come out with certain documents which have been well received by the health professionals in the country. And Dr. Roli Mathur, as the head of the bioethics unit of the ICMR, and she is going to present these documents. What are they and what are their contents? The actual speaker for the day, as far as the topic is concerned, is the doyen of palliative care in this country, Padma Shri Dr. M.R. Rajgopal. He is a palliative care physician from Trivandrum, Kerala, and welcome Dr. Rajgopal, because he is well known nationally and internationally in this particular area. And the most inspired, although he is a physician, is associated with a number of hospitals in Kerala. What is his great achievement is starting a charitable trust called Pallium India in 2003, which has got 2 centers. But what is more important is that this center is responsible for palliative care services in 8 states of India. Naturally, you can expect that he is honored with several national and international awards. But what he is going to tell us is what does you mean by a good death, and how to provide a community-based home care, and the whole conundrum of fighting death as a medical event. That is a topic which is going to tell us that what do we mean when we are talking of a good death to the loved ones? What do we mean by that? The next speaker of the day is going to be, and you go on to the next slide, is Dr. Sushma Bhatnagar. She is a professor and head of the palliative care and onco anesthesia from the All India Institute of Medical Sciences, New Delhi, a government institution. She is a faculty at the Institute of Rotary Cancer Hospital and head of the Department of Pain and Palliative Care. She has been training a lot of students for more than 20 years about pain management and palliative care, especially in cancer patients. And of course, she has also received several national and international awards in this area. Now, she is going to explain to us what is the responsibility and the role of the healthcare providers in this scenario, and coming from a government institution, how much they are able to achieve in this area, and what is their duty of care, as we say, is for the healthcare providers in the end-of-life situations. Now, this is going to be followed up by the wonderful Miss Harmala Gupta. She is known to many people in this country, and she is a wonderful speaker. And what is important is she is a cancer survivor herself, and she has realized the need of support for patients who have been sick. And she founded the Cancer Sahayog in 1991. But what is more important is that subsequently in 1996, she founded the Can Support, which talks about the largest home-based palliative care. So we are going to hear the community-based palliative care, then the government hospital-based palliative care, and then the home-based palliative care from Ms. Harmala Gupta. And she is also we have all listened to her many times. We enjoy her talk, and it comes from her heart. And naturally, she has been a board member in many national and international cancer support groups, as well as hospice and palliative care. Now, she is going to tell us that when we do a home-based care for those individuals who are in the terminally ill, how can we do it much better for their life? How can we make it more comfortable within the home scenario, in the home setup, thereby the whole end of life care becomes more humanized than it is what is when hospitalized in the technology based everything. How do we humanize the end of life care for our loved ones? The last but not least, the last speaker is going to be the most admired Dr. Rajkumar Mani. He is the leader of all this talk which we have been having for many years. He is Director of Clinical Services and Critical Care from Yashoda Hospital, Ghaziabad, New Delhi, coming from a private sector. Now, when I said in the beginning, we are going to have the different aspects. So now we are going to hear from being in the private sector hospital, how Dr. Mani is able to be an authority on the end of life care in this country. And there is no task force, there is no committee in which if Dr. Mani is not there, the committee doesn't exist at all. He has been chairing many of the task forces, many of the consensus guidelines which has been developed by the Association of the Critical Care or by the different institutions and organizations, including us in ICMR. He has been the prime force, the prime pillar behind it. And he has been the past president, naturally, of the Indian Society of Critical Care Medicine and many more national and international recognitions which he has got during his illustrious career in this area. Now, his task is going to be, having listened to all the areas and of course giving his own experience, his task is going to focus on reorientation of the intensive care in this country. How do we use the available technologies, considering the ethical, legal, and the social issues of humanizing the end of life care, that we are not always concentrating on the technology of it and how are you going to humanize it, keeping in mind the ethical, legal, and social issues which are very important, so that we are within the available laws and the guidelines. At the same time, the humanization part is the most important, and that is what is going to do that. So the ICMR Bioethics Unit, which has been mainly working in the last more than 25 years on the areas of ethics in biomedical research. In the last couple of years, we are also looking into the area of the ethics of the clinical practice, and that's why these guidelines have come out. And this webinar is one such, that we cannot do research without practice, and research and practice go hand in hand. And if you have to understand the research and the research guidelines better, we have to understand that what are the issues which are related to the practice of medicine, from which comes out the research component also. And I'm so happy the last few years we are working on this with this doyens in this particular area of end of life care, and they are going to enlighten us today. I'm sure, as Dr. Mathur said, there will be a lot of questions. You can put your questions in the chat box, and in the end, we are going to, if we have the time, we'll address each questions. We'll pick up some of the questions, and then we'll ask the experts to give their opinion. In case there is no time, I'm sure that Dr. Roli will see that the answers are put up in the website later on, in the NCDR website on this, so that all of you, whatever doubts you have, will be clarified. And some of the experts may also give answers in the chat box itself, so that you get immediate answer to that. So with this introduction, I now hand over to Dr. M.R. Rajgopal to be the opening batsman of this session. Over to you, Dr. Rajgopal.
Dr. Vasudha, thank you very much. What an honor. I also, on behalf of everyone in this country, because what's common between all of us is that we will all die someday. And when so many things were ignored by most people, the Bioethics Unit of Indian Council of Medical Research, thanks to the initial interest of Dr. Soumya Swaminathan and then carried forward by Roli, has taken the task over of making life till death friendly for people everywhere, including me. Today is the death anniversary of Dr. Elizabeth Kubler-Ross. She died 16 years back. An American psychiatrist who for the first time studied the suffering that people who have incurable diseases go through, the way they live till death and the way they die. When you read about her, you realize, especially the seniors here will realize, the transformation that we all have been perceiving from our childhood to 2 generations later now. The historian Philip Arrays talked about the transformation from tamed death to forbidden death. What we found in our childhood was death as a part of life, a reality to be seen. We children were actually witnessing how the elders died, and we grew up with that concept of death being a social event, something that is done in the families, that happens in the family's presence, where there are a lot of hugs, lot of kisses, and the rituals that follow generally helps the family members to cope with the loss. That was the tamed death that Philip Harris talked about. I'm an anesthetist by training. I practiced as an intensivist for many years. And in the 1980s, I saw this development of critical care. Ventilators became popular. And that was a great. See, ordinarily, when if somebody is in a hospital, the doctor comes in the morning and there is one round in the morning. Treatment is decided for the next day. What the intensive care did was that multiply that evaluation by every second, instead of once a day to every second. If I am in an intensive care unit, all my functions of vital organs, the chemistry, everything is shown, monitored minute by minute and shown on the screen. And then interventions happen at that point. So that if one system is faulty, others do not become faulty, the intervention happens at that point of time. It was a lifesaver. So many lives are saved by intensive care. But curiously, then something else happens. Curiously, it, rather than being a tool for saving lives, unfortunately, it became a weapon of inflicting suffering. That happens when critical care moved from application in the areas of salvageable situations, became applied to all deaths. So much so, the transformation occurred without our knowledge, so that today we have what Philip Harris called forbidden death. When my time comes, I will not be allowed to die. That's if I have any money in the pocket. The process of death is stretched out, and every moment is a moment of suffering. I know this, I have seen this, because there's a tube down the throat in the most sensitive part of the body, the tracheobronchial tree, where even a fleck of dust makes you cough enormously. That's where a suction condition goes in and out. That's where a endotracheal tube stays in, which a friend of mine who had gone through that process called, it felt like a red hot iron being pushed into my innards and then twisted as it is withdrawn. Ladies and gentlemen, we cannot allow this injustice to continue. This forbidden death is unfair, because by our constitution, I have the fundamental right to life with dignity. I have that right so long as I am alive, and I am alive till I am dead. I don't have the strength to fight for my rights at that point of time when I am dying, and therefore anyone is free to inflict that suffering. As members of a decent society, we have to change this. Elizabeth Kubler-Ross showed us how. She showed what kind of care dying people needed, because what happened in my childhood is not all fair, because then also pain and suffering was not treated. People died in suffering. We now know how to make that life till the last moment devoid of suffering as much as possible, how the family can be together, how the community can come together to support people during that phase, and how death can be no longer an enemy, but one reality to be lived with. I'll take a minute to share my screen and show you just one slide. I hope that is visible. Roly? Shilpa, is my
Yes.
slide?
Yes, it is visible.
Yes, sir. It's visible.
Thank you. These days of forbidden death, the barriers to humane end-of-life care, I would put in these fourth. And in the first, I have put in doctor's perception of duty of care. No, not because the others are important. Doctors always say, but the family comes and insists, the law doesn't allow, etc. But I think first and foremost, we doctors have to realize what is our duty of care. In most countries, that is defined by law, not in India. In India, Indian Council of Medical Research has put it down in black and white in 2018. Indian Council of Medical Research Bioethics, thanks Dr. Vasudha, Dr. Rolly, Dr. Prashant, you all defined it, that the healthcare provider's duty of care is to mitigate suffering. It is to cure sometimes, it quotes the 14th century aphorism, cure sometimes, relieve often, and to comfort always. And the Indian Council of Medical Research adds, there is no exception to this rule. There is no exception to the rule that the doctor's primary duty of care is to relieve suffering. And that is what precisely, not only we are failing to do, we are inflicting suffering. We are inflicting suffering by not treating pain and symptoms. We are inflicting suffering by inhumane incarceration and imprisonment, isolation of people who are dying, where a hug is more important than anything else in the world. And we are causing catastrophic health expenditure, which today destroys 55 million Indians every year. Very often, families think doctors do this for money, for making more money for the hospital. I do not think that may be partly true in some cases, but the main reason is doctors think that they have a duty to prolong life at all costs, to prolong the dying process also, to keep the heart beating at all times. Instead, first and foremost, healthcare providers have to receive this message that their primary duty is to mitigate suffering. They also have to accept that death is the inevitable consequence of life, and they have to make it compassionate. Of course, over this generation, I mentioned 1980s, between then and now, families also have come to accept a death in ICU as the norm. They didn't invent it. We invented it. And they accepted it. There is this conflict between a selfish kind of love. I can't let my mom go. I can't live without her. Instead of that, they need help. They need conversations. They need the community's involvement to realize that that is selfish. I see she is suffering. I have to relieve her suffering. Therefore, though the healthcare provider's duty of care has to change, the society's perception of death itself has to change. That means engagement of the community. And several societal factors will come in the way, including religious beliefs. Ideally, that should be supportive to humane end of life. But when, unfortunately, the Supreme Court of India in 2018 called withdrawal life support euthanasia, ICMR document which was brought out 4 days later said that that's a misnomer, unfortunately. And immediately, one religious party, one religious group came out with a statement that we fight it. We will fight this judgment. And I have put in legal barriers last. That is my most important message. Okay, we do not have a law covering end of life care. We have a Supreme Court judgment for which has been found in the last 3 years to be impossible to implement because of the procedural barriers. There are legal objections. But ladies and gentlemen, let me make this own statement. When do the legal questions arise? Only when the duty of care is in doubt. If I know what my patient needs is pain management, symptom control, compassion and love, and we make that happen, and if the family approves, the person dies a natural death with compassion. The legal issues may not come up. We made it into a legal issue by changing death from a social issue to a purely medical issue. We brought in the legal complication. The legal issue, okay, there is no law, but the law doesn't have to come in at all if between the patient and family their duty is accepted. Essentially, this is what Elizabeth Kubler-Ross advised. This is what she went on talking all her life. And somehow we have to make this happen. We have to turn things around, making it a safe world for all of us to live in the last few days of our life and die peaceful deaths. Thank you very much.
Thank you, sir. It was indeed very engrossing and left us wanting for more. Moving forward, the next talk for today is on ethical issues in end-of-life care. What is the healthcare provider's duty of care? And to present this, I would like to invite Dr. Sushma Bhatnagar. Over to you, ma'am.
First of all, just a minute, let me do this right. First of all, I would like to thank Dr. Roli Mathur, Dr. Prashant Mathur, Dr. Vasudha, and overall ICMR. I'm so happy that today this activity is happening after they have come out clear-cut definitions on all these aspects. After they have come out in 2018 that what is DNR and what is what exactly the healthcare provider should do as far as DNR and other these policies are concerned. So they have come out with this very important webinar, and this is for public. And Dr. Roli Mathur, Dr. Vasudha, and Dr. Prashant Mathur, I would like to speak in Hindi because this is happening for public. So I hope I'm not wrong, but I will speak in Hindi. Is it okay? So I'll go ahead. Dear friends, my elders, मेरे दोस्त लोग और मेरे छोटे बच्चे जो अटेंड कर रहे हैं, see the progress of medicine. जब हम लोग मेडिसिन में स्टार्ट किया था, तब से प्रोग्रेस ऑफ मेडिसिन बहुत आगे आ गई है. हम लोगों ने स्टार्ट किया था फ्रॉम which doctors means उस समय से I remember that small pox और chicken pox को हम छोटी माता बड़ी माता बोलते थे. And most of the time हम लोगों का ये होता था कि कोई पूजा कराओ, पाठ कराओ तो ठीक हो जाएंगे. So उस समय से हमने मेडिसिन ने स्टार्ट किया और बहुत कुछ आगे आ गए हम लोग. एंड अभी जो स्टार्ट करके हम लोगों ने जो वी हैव रीच्ड इन द लास्ट 4 डिकेड्स में सबसे ज्यादा एडवांसमेंट हुए हैं. और ये वर्ड हम लोग रोजाना डेली सुनते हैं: इम्यूनोलॉजी, मॉलिक्यूलर बायोलॉजी, नैनो टेक्नोलॉजी एंड रोबोटिक्स. एंड व्हेन अ पेशेंट receive all these therapies, we feel very happy that okay, my patient has received everything. But when this therapy does not work, then we feel very bad that oh God, this therapy has not worked. So there are positive aspects of all these therapies and there are negative aspects of all these therapy. पॉजिटिव एस्पेक्ट इनके क्या है कि कैंसर जो एक जमाने में था दैट कैंसर एंड डेथ सिनोनिमस था, वो अब क्योरेबल हो गया. बहुत सारे कैंसर्स हैं जो अब क्योरेबल हैं. लेस इन्वेसिव थेरेपीज आ गई हैं, इंक्रीज लाइफ एक्सपेक्टेंसी हो गई है, और 5 ईयर सर्वाइवल, अगर किसी डिजीज का अगर हम टर्म्स ऑफ 5 ईयर सर्वाइवल करें तो देयर आर मेनी डिजीजेस जिसका 5 ईयर सर्वाइवल इज वेरी वेरी हैज बिकम इम्प्रूव्ड. Emerging pain modalities आ गई और better drug profile हो गया. These are all positive aspects, and medical science has really worked hard so that person should have as comfortable as much as possible, and they should have a good quantity of life. but the negative aspects are there. Negative aspects क्या हो गया? Increase life expectancy हुई है, but at the cost of growing complications. हम life expectancy increase करने के लिए हम अपने better drugs को देते हैं, but at the cost of growing cost. And once we pushed all these costs if we can afford, but we are not worried. We are worried about if we, as Dr. Rajgopal has said that we put our patients in ICU, ventilators, but we are struggling with ventilator associated pneumonia and new drug resistant flora. And we are really worried that how to handle this. Most of the conferences are discussing in these days, यही चीज discuss करते हैं कि कैसे fight करें और कैसे हमारे patients को save करें. And ultimately the worst thing has happened is we have forgotten completely that person whom we are treating is ultimately a human being, and we should treat him and quantity of life is important, but not at the cost of quality of life. So quality of life is equally important. So we have completely forgotten this thing. Now, the worst thing which has happened of medical science, सबसे ज़्यादा worst क्या हुआ है कि जो medical system में trust था. जब मैं डॉक्टर बनने वाली थी तब मुझे ये पता था कि डॉक्टर को लोग, ऐसे नहीं है कि मैं भगवान बनना चाहती थी, बट उस समय डॉक्टर को लोग भगवान मानते थे. लेकिन इस समय ऐसा नहीं है. एक कोई सी भी बीमारी हो जाए जो बहुत ही क्रॉनिक है और मोस्ट ऑफ द टाइम इनक्योरेबल है मान लो, तो वो पेशेंट हर हाल में 3 या 4 डॉक्टर से ओपिनियन लेने जाता है. ऐसा क्यों होता है? बिकॉज there is not transparency, there is no good communication. Transparency होगी तो good communication नहीं है, and there is a completely loss of trust in healthcare system, and people are not having any trust in healthcare system. Can I just do the slideshow? Just 2 minutes. Give me 2 minutes. I will do the slideshow. I'm not able to do it straight. Anyway, so what happens when patient is in advanced stage? Any medical institution has this responsibility कि क्या हमारा पेशेंट क्या चाहता है जब वो पेशेंट एडवांस स्टेज में चला जाता है. बिकॉज ये तो मान के चलिए कि डेथ इज नॉट ऑलवेज, ऐसा नहीं है कि वी कैन प्रिवेंट डेथ, एंड अल्टीमेटली डेथ इज इनएविटेबल. समटाइम्स पेशेंट इन एडवांस स्टेज में है एंड व्हेन क्योर इज नॉट पॉसिबल, salvageability is not possible, we have to think something else. What patient wants in this stage? Patient अपने डॉक्टर से चाहता है कि they should give me the information on current status and future course of prognosis. They should give me honest, complete communication by healthcare providers sensitively. So healthcare providers की क्या जिम्मेवारी रहेगी यहाँ पे कि वो उसको sensitively इसको अच्छे से समझा दें कि what is happening to the patient. Patient wants to have a freedom from pain and suffering and reassurance. See, when patient is in advanced stage, they are going to have something like pain, suffering, symptoms. बहुत सारे symptoms होंगे. They want that my doctor should reassure me that cure is not possible, but we can give you complete confidence that we will be relieving your pain and suffering. They want increased control of life to maximum possible, because everybody wants the quality of life and they want that everything should be in my control. But you know, hardly it happens. हम अपने मरीज को अल्टीमेटली बिल्कुल साइड में कर देते हैं और सब कुछ डिस्कशन हमारे फैमिली मेंबर्स के साथ हो रहे होते हैं. उसकी कंप्लीटली वो क्या चाह रहा है, ऑटोनॉमी कंप्लीटली, मेडिकल एथिक्स का जो फर्स्ट प्रिंसिपल है वो कंप्लीटली हम वेनिश कर देते हैं हमारी ट्रीटमेंट प्लान में. सो दिस इज व्हाट दे वांट, दैट दे शुड वांट, दे वांट दैट आई शुड डिसाइड माय ट्रीटमेंट. दे वांट रेस्पेक्ट एट ऑल लेवल्स. They want empathy, not sympathy. Most of the time जब भी हम जाते हैं, sympathy तो हमारे अंदर होती है, but empathetically. So doctors should have a empathy with the patient and easily approachable expert. कि अगर मुझे मान लो कि घर भेज रहे हैं और अगर मुझे कुछ तकलीफ होती है तो मैं किसके साथ कांटेक्ट करूंगा, अगर मुझे कुछ समझ में नहीं आएगा तो where should I go, ये सब चीजें एक पेशेंट को चाहिए होती है. ठीक है, अब हमारे को नेक्स्ट आता है कि उसमें हेल्थ केयर सिस्टम कैसे हेल्प कर सकता है. हेल्थ केयर सिस्टम हेल्प कर सकता है दैट दे हैव टू लर्न. आई कैन अश्योर यू दैट कोई भी डॉक्टर किसी भी पेशेंट का बुरा नहीं चाहता, बट ओनली थिंग जो लैकिंग है वो है कम्युनिकेशन, कम्युनिकेशन एंड कम्युनिकेशन. सो दे हैव टू कम्युनिकेट एंड दे हैव टू रीकम्युनिकेट. They have to provide information at the patient pace of acceptance, because बहुत सारे patients होते हैं जो एक ही बार में सब चीजें समझ जाते हैं, but बहुत सारे patients होते हैं जिनको बार-बार reinforce करना होता है that what is the realistic hope possible from the treatment. So they have to keep giving realistic hope and honest information at all the level. Empathetically making patient and caregivers feel empowered. अगर patient को घर भेज रहे हो तो patient किस तरीके से family members उस patient की care करेंगे, this you have to teach at all the levels. Involving families with patients unable to express. अगर patient नहीं समझ पा रहा तभी family को भी involve करना है, but family को शुरू से involve करना है. But अगर patient is understanding everything, I think patient, family member and physician should make a party, and they should take care of the decision. They should be making the decisions. Reassuring freedom from pain and suffering at all the levels. This is most important, that we are not curing the patient, but we are not deserting the patient, and we will make all the efforts that they will remain pain-free and they will not be having any suffering. Next, what is the responsibility of any medical institution? That they should respect culture and family belief and tradition, that what exactly the patient's family belief and tradition. And then provision of professional counseling if required. Agar patient ko bilkul nahi ho raha counsel, to how we can provide professional counseling, this is most important. So medicine should always include that life is important. We are going to respect life, we will affirm life, but we will regard dying as a normal process. So death is, when diagnosis is a normal process, when treatment is a normal process, so death is also a part of medicine. So medicine का एक part है. तो patient public के लिए भी जरूरी है कि समझना कि when diagnosis हो गया, treatment हो गया और treat नहीं हो पा रहा, तो फिर death भी एक part है, और उसमें doctors की responsibility ये नहीं है कि उसको treat करेंगे और cure करने की कोशिश करेंगे, but उनकी responsibility है कि death को dignified and कैसे करें, वो उनकी responsibility है. We have to promote quality of life. This is a very important for public as well as doctor, that quantity तो सबके लिए important है. हम सब चाहते हैं कि हमारे elderly, हम सब खुद बहुत दिनों तक जिएं, but not at the cost of quality of life. We need to treat a person, or we have to support the family. Now this is my last slide, and I wanted to show in the slideshow, but it is somehow not coming. We have to create a system ultimately where we want to die. Most of the people, or especially the VIPs and other doctors and all, we all die in ICU with all the ventilators. But this photograph especially I brought today, this is me and this is my mother. When we realized कि मेरी mother अब नहीं रह सकती और क्योर नहीं हो सकती, तो हम चारों भाई बहनों ने डिसाइड किया कि हम उनको ट्रीट नहीं करेंगे. ऑल्दो वो हॉस्पिटल में थी, बट वो आईसीयू में नहीं थी, और 7 दिन तक वो हमारे साथ रही और हम सब उनके साथ रहे. आई डोंट नो किसने ये फोटो क्लिक किया, बट ये फोटो मेरी हर क्लास में काम आता है कि इस तरीके से मैं अपनी मदर को अपनी गोदी में रख के भेज सकी इस संसार से. आई थिंक वो मुझे ब्लेस करती होंगी. इसी तरीके से हमको भी समझना है, पब्लिक को भी समझना है कि डॉक्टर्स की अल्टीमेटली एक लिमिट होती है, जब उसके बाद डॉक्टर्स कुछ नहीं कर सकते. और अगर वो समझाने की कोशिश कर रहे हैं तो उनको समझना चाहिए कि क्योर इज नॉट पॉसिबल, कंफर्ट इज ऑलवेज पॉसिबल, एंड आईसीयू सबका आंसर नहीं है, और हमें डिग्निफाइड एंड देना बहुत जरूरी है अपने लव्ड वंस को. थैंक यू वेरी मच. थैंक्स.
थैंक यू मैम, धन्यवाद मैम. बहुत ही हार्ट टचिंग और बहुत ही मैम, इट वुड हैव डेफिनेटली एनरिच्ड सारे पार्टिसिपेंट्स को मैम. थैंक यू मैम. मूविंग अहेड, द नेक्स्ट सेशन फॉर टुडे इज ऑन ह्यूमनाइजिंग एंड ऑफ लाइफ केयर एट होम. How can we do better? And in this regard, we will be playing a small video highlighting the importance of home-based care before we move on to the actual session by Ms. Rajkumar Gupta to share her views on this topic. So we'll be playing the video now.
क्या हुआ अंदर?
हाँ बोलो.
हाँ.
बीपी ठीक होना चाहिए.
कोई बात नहीं, हम आते रहेंगे, चेक कर लेंगे.
कब तक खाना पड़ेगा दवाई?
दवाई तो अभी टाइम रहेगा, थोड़ा लंबा टाइम. हाँ, लंबा टाइम खाना पड़ेगा. अभी दवाई चल रही है ना, दवाई ठीक. हम अच्छा सोच के चलेंगे ना.
ठीक है.
ठीक है
आगे वही माँ भी करें।
बिल्कुल
और क्या है तुम्हें?
मैं तो ये चाह रही हूँ थोड़ा आराम से थोड़ा उसमें सुधार हो जाए हल्का फुल्का।
अभी इससे सुधार तो ज़्यादा नहीं ला सकते, इससे सुधार ज़्यादा नहीं ला सकते। ठीक है, अभी कम से कम आराम से लेटी हुई है,
हाँ, बस वो
आराम से लेट
रहे हैं।
हाँ वो नहीं कर रहे, उनको दर्द नहीं है, उनको पीसफुल माइंड है, ये तो चाहिए ना हमें।
यहाँ कुछ हो जाता है तो कैसे लेके जाएंगे, इस बात का डर लगता है। तकलीफ बढ़ता है, मुझे पता चलता है।
बिल्कुल आपको पता है।
कि मैं कब तक रह सकता हूँ, और वो तो पता नहीं है ना, अचानक हो जाते हैं। टकरा गया चला गया। अब अगर पहले आपको पता चले जब मरेंगे तो आपको लगता है ना जब अभी मर जाएंगे ना क्या, या कल मरेंगे या 2 साल बाद मरेंगे, डर तो लगा रहता है।
Ma'am, I would now like to invite Ms. Harmala Gupta, ma'am, to please share her views, ma'am. Over to you, ma'am.
Thank you so much. I'm really happy to be here among you today. And what you just saw was really just a snippet from a film that has been made on our home care teams and their work. And I think I just wanted to give you a flavor of what it means to visit people in their homes and to be with them at a difficult time in their lives. My question is this to medical practitioners and health practitioners. Can you see me as a human being? Because I sometimes doubt it. I am a survivor of cancer. I was treated. I was immediately labeled. I'm Hodgkin's stage 4. And the attempt is always now to classify me, to put me into neat boxes. So someone comes to me and says, how did you feel when it was broken to you, the news? So I said, well, it was a terrifying moment. Okay, shock. Tick mark, shock. Okay, let's move on. Were you in denial? I said, yes, of course. I thought, how can this happen to me? I never knew I could get cancer. Fine, let's move on. Tick, denial. And it goes on. The problem is, you can no longer see me as a human being. You cannot understand that word which goes beyond just physical health, which is called well-being, which is called humanness. And may I say, you have paid a price for it. Because my next question is, can you see yourself as a human being? I sometimes doubt it. And that is a terrible price to pay for what you have become and the degrees you have earned. Because finally, it is that humanness in you that is going to see you through every moment of life. And I think that this pandemic, COVID-19, has been a blessing in a way. Why do I say it? Because the whole world has suddenly realized the importance of connectedness, the importance of human contact. And this has happened everywhere. I recall this nurse who was in her protective gear, gloves on, she talks about the fact she's looking after a woman who for 25 years has been her friend in that nursing home. These are her dying moments. Her family cannot be there. Everyone is away. And here she says, I look like a creature out of space. I'm standing there. As she approaches the end of her life, she extends her hand towards her. And she said, I had been instructed, do not take off your gloves. She says, I took off my glove and I held that hand. Why? Because I could not have lived with myself after that. This was the moment of the human connection. Why do you think so many suffered from post-traumatic stress disorder? Because they were not given the opportunity to experience that human connection. And this is so wonderful in what the work we do in home care, because we have the privilege of coming in, leaving our shoes outside, the shoes of the specialist, of the scientist, but entering as the human being to meet another human being who is being claimed by, we call it death. It's being claimed by something over which we have nothing to offer except I would say, please get out of the way. The wave has come. The ocean has come to claim its own. You built the mandala. You built it with your family, and it's important that they all be there to witness this with you. You built the mandala. Now comes the moment of destruction. It has to go. It has to be destroyed. But what do you want? You want empathetic people with you. Around you, people who now speak a different language. Not the medical language. Not the language you and I have been taught. But the language that has been there from the beginning of time. The language of our ancestors who could not read or speak. It is the language of feeling. What we need now is to revive that language of feeling. And it doesn't matter whether that person can hear you, whether they can see you. They can feel you. Never doubt that. And that's what our primary purpose has to be in those final weeks, those final hours, to reinforce the fact that this person is not alone, will never be alone, that we are there, yes, to provide comfort, to provide pain relief, all the wonderful things we heard about, which are important. But most importantly, we are there to watch over this person. And by doing that, we are doing the greatest service. This is a precious moment. Yes, we need to go through all the rituals that a doctor goes through. I remember Dr. Abraham Verghese writing in his book, My Own Country. He was a country physician looking after HIV/AIDS patients. He says this is the last visit to a patient he's been looking after. Patient is a few minutes perhaps from death. He cannot communicate, but he says he makes a gesture as I enter and tries to remove his shirt to one side. He says, I get it. He wants me to put the stethoscope on his chest. The connection. And this is what I tell you, the healthcare fraternity. This is a sacred connection. the connection between now no longer a physician and a patient, but a connection between two human beings, completely naked human beings, no pretenses now, sharing in that pain, which is a common pain, sharing in that moment of destruction, which is a human, which is a universal thing. We're all going to face it. We can't fight it. All we can do is try and move with it in the best possible way. And I think home care is marvelous because that person is in familiar soundings, his surroundings, they're with their memories, their loved ones. They have a chance to take one final look at that mandala before it is destroyed. And I think that in itself is so important for their own wholeness, because when we leave, we have to leave feeling whole, feeling healed, feeling what we are, the beauty of our humanness. It is not, I mean, lives are ugly, it's true. Human beings are complicated, it's true. But the point is that there is beauty in that, a beauty which we must never miss, a beauty which defines us as human beings. And this is what I would say, we want to do it better. Okay, let's do it better by being more human, by thinking more about the way we communicate, by reaching out, by spending time, by investing our emotions, by allowing us to feel, by being the best we can, by helping the caregivers, the family, to be the best they can in that moment. And to help me, the person who now is still clutching on those pearls. The pearl necklace has broken. The pearls are scattered, but I'm still clutching on to what remains. Because till now, that is what gave my life meaning. And the need now to let that go. And that's the effort. When our teams go in, how can we work with you, with the family, with love, connection, understanding, and we listen. That's our greatest tool. We listen, and we are there with you. That final effort will have to be done by you to let go. And help us help you let go. And I can tell you, the greatest need is just that. Just be there for me. Let me feel your presence as I feel my humanness, which includes death and destruction. The preciousness of life is because it is short. If we lived forever, life would have no meaning. So it is a precious moment. It's a sacred moment. Let us all accept that. Let's work with this person. And more than that, look at the opportunity we're being given to experience our humanness, the humanness that we often suppress because we've been told, don't show your feelings. It's unprofessional. It's not the right thing to do. It will cloud your judgment. No. Being human can never cloud your judgment. Being human gives you a special insight. Being human makes you what you were always supposed to be, a healer. Being human gets you to recognize, I'm not just the body. Don't cut me up with your specializations. I'm not my liver, I'm not my kidney. I'm not my tumor. I am much more than that. See me in the wholeness. Where did the generalist go? The generalist who could see me totally, who understood me, where I came from. Maybe that's what we've lost. Maybe that's what we need to reclaim and go back to, which is why in palliative care, the general physician has such an important role. We don't need specialists there. We need to build that. Our nurses, our wonderful nurses who are there to talk, to encourage. Yes, you need courage. Oh, yes. You can't do without courage. Everyone in that situation needs courage. How do we build that courage? That's the question. How do we build the courage in the family? How do we build the courage in the person who is going? How do we build the courage in ourselves to be able to accept that there is nothing more we can do? That requires courage. You talk to me about denial. I'm in denial. What about the doctor who, when I am dying, still asks me if I'd like another round of treatment? Who is in denial here? Let us remember that we are human beings. We share a wonderful, beautiful planet. We are connected. Our social structures, everything that we stand for depends on this connectedness. Why do you think people are on the streets saying no more? We are not going to maintain this distance from each other anymore. Because they know this virus is not just hitting our bodies. It's hitting our entire being. It's destroying the human element in each one of us. And that is terrifying. And so I would just conclude to say.
Yes, Ms. Gupta, can you just summarize? And
Yes.
Yeah.
That all we need, Dr. Vasanta, finally, is to allow our humanness to come. We are the greatest tool that we can give to anyone. We don't need any additions. Thank you.
Thank you so much. Yeah. You are muted, please.
I'm unmuted.
Yes.
Can you hear me, ma'am?
Yes, please.
Cruising along, I take immense privilege as I invite Dr. Rajmuni to share his views on reorienting intensive care using technology wisely, considering the current social, legal, and ethical dimensions. Over to you, sir.
Now it's a great privilege and honor to be part of ICMR and my very esteemed and dear colleagues on the journey of EOLC, end-of-life care, improving the way we die. Can I have the screen? Yeah, thank you. So, I heard intently all the beautiful talks, and they have touched upon many areas. But in this short time, I must touch upon certain areas which are very important on the ground. See, I've been an intensivist all my life. It's nearly 35 years now. And the overriding goal, right from the early part of the career, has been to save lives. Okay, even the whole mission of intensive care since the 50s has been to salvage. Okay, so there's been a lot of revolutionary advancements in life-saving technologies and also life-saving therapies in general in medicine. So revolutionary means suddenly, with a degree of rapidity, you see the outcomes change. And it's marvelous. It is a romance of medicine and intensive care. And then is followed by evolutionary changes where there are further and further refinement and improved outcomes. It's not for nothing that the life expectancy, which was 32 in the 1930s and early 40s, is now nearly 70 years for Indians and much, much more rest of the world. However, this romance gave way to realism very soon. So in the West, which saw the advent of intensive care much earlier than us, also stumbled upon this reality that there is a huge obverse of the coin, which is that we create a lot of harm as well with technologies that fail and technologies that are not wisely applied. So there are campaigns in the West, treat wisely, less is more. So concurrently with greater and greater push at technology, there's been the campaign to be more thoughtful in our treatment, in how we plan and how we treat. Yes, of course, technology is for the human being, not the other way around. Technology is not an end in itself. Technology is for the human being. All the soft skills that we need as a healer is for the human being, of course. And as Harmala said, yes, it is imbued with a spiritual meaning, and we increasingly realize, the palliative care specialists and intensivist physicians all over the world realize the importance of a spiritual presence by the bedside. Now, you see, there was a shift in the paradigm of our thinking in the world in the 1980s. All right. There was the re-look at the biomedical ethics, and the biomedical ethics have evolved since the early 1980s with seminal publications. So ever since the 1990s, there has been a push towards understanding when to make the switch from a treatment with a curative intent with a treatment with a palliative intent. Okay. So there is a so-called goals of care determination became essential since the 1990s in the world. And that's how the evidence-based medicine came about, which integrated these principles. Now, where have we fallen short? We have kept pace with the advances in medicine. The technology push has been tremendous in the last 10 to 20 years in our country too, and we are abreast of the times in most of the cutting-edge interventions. However, I must say, to ICMR Biomedical Ethics Unit and also to India and my colleagues across the spectrum of profession, that our ethics have not kept pace with the advancement in it. How can it be? How can you extend as a tree but not go deeper in the roots? Is that possible? We'll soon wither and lose our way, lose our purpose, and create more tyrannies than solve problems. So technology as an end in itself, the view has also made us very defiant and denying of death. Now, we are not looking at life as a whole. We're looking at it at just the snapshot. And life and death is a binary thing, not as a unified thing. Death as a failure of medicine, rather than inevitability of human life. So as an intensivist, as many people as I salvage, a large part of the rest I'm not able to salvage. My friends across the globe are witness to mortalities, deaths amidst themselves on an everyday basis. Can we only say that I'll manage the surviving but not the dying? We are healers. To alleviate suffering always, that's the motto, that's the mission. How do we manage death? That is the question we in our midst have not addressed properly. How do we manage the dying appropriately? Not burden them with more technology interventions, neglect, all right, or inappropriate care in general. That is the question which in our country we have yet to address properly. We never talk about the dying. We talk about euthanasia, right to live and all that. We don't talk about what happens when you're dying. How do we care for you? How do we rationally get there? How do we judge when the time is over and death is inevitable? We have reached the point of no return. Now, these are the professional challenges which the profession must accept, right? We are denying it at the moment. We are saying that's not my job, which is an incomplete view of ourselves as a professional. The quality of dying index is very low for India in the world. We're 67th among 80, and not for nothing, because we don't address these issues. We are not seen the facts as they are and come up with solutions. We've got alibis, plenty of alibis. So firstly, the culture of looking at death, opening up the question, unabashed, unafraid. Number two, opening the question. Properly, a conversation between the public and the professionals in general. These two are very important. Number three, creating the proper environment and training and education of the professions, caregiving professions, who are constantly dealing with this. You see, the majority of deaths are taking place in the ICU. Whether or not you take an early decision, in the end, they land up in the ICU, find themselves in very horrific intervention. Nowadays, it's not just stopping at ventilation. It is coming to ECMO, extracorporeal membrane oxygenation, which is a technology by which even if your lungs and heart are gone, you can be kept alive, even if they are gone irretrievably. If the brain is gone irretrievably, you can keep them alive with ventilation. If the heart and lungs are gone irretrievably, you can keep them alive with ECMO. Now, these are the meaningless approach to medicine. We are not modern day Vishwamitras, the Muni Vishwamitra, who kept Trishanku in the middle, neither of the earth nor of the heavens. We are not like that. We are human beings. Last 1 minute I want to spend on what are the efforts being made towards resolving this issue and to come up to date with human knowledge about the subject and come up to date with the human endeavors to bridge this gap in medicine and humanizing medicine. Firstly, we have come a long way in the last 15, 20 years in this country in self-education and awareness, building capacity for working toward this goal. Number two, we have always been bothered about the legality. We haven't talked about the ethicality, the ethics of it. Our focus on ethics has to be improved. Focused on humane care has to improve. And lastly, law has to be informed with the centrality of ethics and professional duties of care. They can't be standing alone. In law, I must say, we have come to the constitutionality of withdrawal and withholding of life support. We have come to the constitutionality of do not allow attempt resuscitation. It is in the procedural aspect that we have complicated it, and we are in the process of simplifying. But I must say, patients must know their rights. They have the autonomy. They have the right to refuse treatment which they don't want. So the law is not in the way there. Law is actually promoting and further strengthening your right to autonomy. And physicians must understand their duties of beneficence and non-maleficence, which is to the whole person, not just to the body. And first of all, do no harm and do your best to promote the good, the overall welfare of the patient. So I must stop here. because it must have generated a lot of questions, our brief talks. Thank you for this opportunity again.
Thank you, Dr. Rajmuni. I think after listening to all these talks, the one session which we could have had in the beginning, I wanted to have it in the end, because now it will be clear for you to understand what are the documents which ICMR has brought out in the recent times. So I request Dr. Roli Mathur to give that information before we move on to the question and answer session. And thanks to all the speakers for the wonderful talk and the interest which have generated among those who are listening to the same. Yes, over to you, Dr. Roli. Yeah.
Thank you, ma'am, and thank you to all the speakers. I mean, this has been really moving. It has moved us all, and I don't have much to say now, but I'm really grateful to all of you who have joined us today. And as we begin the discussions on this extremely difficult topic to deal with, at ICMR, we did realize the importance and the need to begin discussions on this and to develop an ecosystem that supports end-of-life care, a system that would help to cater to the needs of those who are in pain or in terminal condition or those who are elderly. And how do we make sure that people get what they want? Humane, comfort, care, compassion, safeguarding their ethical, moral values, their dignity, rights, all of these principles that we do not want people to suffer and those be respected. So this topic, which is not much discussed, but then again, I have to thank Dr. Rajgopal and Dr. Rajmuni, who actually, spoke to DG ICMR that there was a need for ICMR to form ICMR Commission, which was appointed in 2017-18. And a group of experts, core members and other members who join into the discussions to initially begin the exercise of developing definitions, because we did not even know how to define some of these terminologies. What is terminal illness? What is life-sustaining treatment? What is death? How do you define death? Withholding, withdrawing treatments, palliative sedation, so many terms which you see in the bottom. This document was developed by this group of experts and released by our late professor, Dr. Madhav Menon, who was our chairperson for the Central Ethics Committee. And it actually provides some clarity and reflects the consensus today in terms of terminologies nationally, and it is in line with some of the international thoughts about this. And this also came out as a publication in the Indian Journal of Critical Care Medicine. And the next initiative that was taken by our current DG ICMR, Dr. Bhargav, who really felt that there was a need of coming up with a policy on DNAR, do not attempt resuscitation, in patients, where non-beneficial CPR is, the cardiopulmonary resuscitation is given. So this was another committee that was appointed, and again, the list of members are there, and a multidisciplinary team of stakeholders besides these members were involved, who looked at this document and provided comments before it was finalized, and it was published in ICMR and NMJI, National Medical Journal of India, and Indian Journal of Medical Research. And this is another document that would be useful for clinicians, physicians, because it tells about how to make informed discussions with patients or their surrogates and families regarding CPR when the patient's chances of survival are extremely low, and when it is realized that there is a likelihood of increasing the suffering, and further it may deteriorate the quality of life. And therefore, this document has given an algorithm. It has a Q&A, frequently asked question answers. So, and how to, a form has been given, and it has explained the whole procedure of going through DNAR. And this is some of the publications that have been made in this regard. So basically at ICMR, we are very keen that we need more discussions for better understanding and clarity, and need a more ethical, person-centered approach. And I think that this meeting would serve as an impetus to develop an India-specific ethical legal framework for end-of-life care. And as it is, we have realized the topic is not discussed much, and therefore we see this as an opportunity to connect with the public, to listen to all of you, to understand your needs and requirements, to learn from your experiences, which will guide us in planning our next steps. Thank you all very much for joining us today. Thank you.
Thank you.
Ma'am, there are
Yeah.
some questions in the
Yes,
chat.
yeah. Thank you, Roli. Yeah, I have just noted some of the questions. I will just raise the question, and I think one of the members can answer it. The first question which has come is that I think Dr. Mani probably may answer. Do we have a DNR provision in the Indian law? Somebody is asked. So having said about this document, the question is that,
it's very clear in the law that there is constitutionality of withdrawal and withholding of life support in the appropriate circumstances with the appropriate, safeguards. Now, DNAR is nothing but a withholding decision. CPR is a medical intervention. It is not a default intervention. It's not a ritual to be done in modern times before death. It has to have its own indications, and it has its futility, and therefore the doctor is not obliged to prescribe it. But what the DNAR document prescribes is opening up the question of CPR well in time so that we can have a DNAR decision based on an informed choice by the patient directly or through a surrogate, appointed surrogate, or the natural family. This is very important shift. The shift is that you are not taking any unilateral decision, which is what is recommended by the courts as well. That all withdrawal withholding decisions must be participative of both the family and a group of responsible medical men and women, of course, not unilaterally. So the principles are well defined in law. Procedurally, they need further articulation and simplification. If you ask me if DNA are allowed in the law courts, of course it is. And law courts would not allow you to override a patient's refusal of any treatment, of course. That is common law. It's already existed. Okay, there's a right to refuse.
Yeah.
There is a right of choice for the patient and indirectly for the surrogates in the form of the need for consent. Inherent in consent is a right of refusal. So please be conscious that if there is a informed choice or a clearly and consistently enunciated choice by the patient for not having CPR, that has got to be respected in law.
Thank you, Dr. Mani. I think Dr. Rajgopal, there are questions about the families, dilemmas. So there are two questions regarding. One is that in a family situation, how does the family decide as to whether to continue treatment or say, yes, you can stop treatment? This is one. The others, the dilemma regarding the family raised by one of the person is that in nuclear families, they depend on the caregivers for the taking care of the terminally ill. And the caregivers, if for prolonged patients, after some time, they become physically and mentally exhausted themselves. So how do the nuclear families handle such situation? So these are the dilemmas within a family. There are two questions here. Dr. Rajgopal.
Thank you, Dr. Muthuswamy. The first question is about, sorry, the second was about nuclear families and the first was?
Yeah. First of all, how do they take a decision to say yes or no? Yeah.
The family, how do they take a decision? Listen, if I am the patient, this is my life. This is also the family's life, but secondarily, primarily, this is my life. By the common ethical principle of autonomy, or even by law, my wish is most important. The best thing is, what I would advise everyone to do is that we all have to die someday. Please discuss it with the family. It is important for our safety for the future about what our wishes are. My family, ethically, morally, legally, should respect my wishes. Their decisions should be based on my decisions. when they don't know what to do. Of course, I mean, if I had not expressed my wish, this was something unexpected. Here is the problem. They may, out of love for me, want to keep my heart going for a little while longer. That is unethical. It is illegal because they are acting against my wish. They are violating my, with all good intentions, out of love, they are violating my autonomy. So the family shouldn't really do what is best for the patient if the patient cannot express a wish. But here, the society's role becomes important. The society exerts pressure. Hey, why don't you take him to that hospital? Are you worried about losing money? That kind of pressure comes in. So one of the things that we talk in advance with our patients and families are what to expect. And when we talk to a loving son or daughter, we prepare them in advance. Make up your mind that you will continue to do the best for your dad or your mom, not to please someone else. Once that is discussed and they are helped to make that decision, it's easier. Of course, the nuclear families issue, that's a reality. That's the way of the world. We have to accept that. But that makes it very tough on the patient, and that makes it very tough on the family also. I mean, all the time, we all keep blaming very often. Today's children have no love. They all run away and they don't take care of our parents. But that's the world that we built for them. That's the reality. We encourage them to fly away. And now they are in a dilemma. So what happened in other countries where the nuclear families emerged later? However inadequate, they built a system to care for people. Just as Dr. Mani said, we allowed medicine to grow without ethics, without growing ethics concurrently. Here also, we allowed this societal transformation without making provision for those who are going to be subjected to this inhumanity and indignity. The solution that we have developed, this happens in cancer support in Delhi, this happens with us in Kerala, is to allow the family to come in and allow the community to come in and help. Can you think of any community anywhere in the world which doesn't have a few people who get happiness out of helping others? They're there. Only thing is, we have closed the doors of medicine. We don't allow them in. We open the door, allow the community to come in and help. They will help. And institutionalizing elders will be necessary today. You cannot do without that because many people are going to be abandoned. That's a social reality.
Thank you, Dr. Rajagopal. This actually leads to the next question. Probably Dr. Sushma can say that somebody who is in the terminal stage, who understands that their pain and suffering is so much, they cannot bear it anymore and life is going to be very short. Can they ask for, mercy killing or euthanasia? So if there is nobody else to take decision for themselves, can they ask themselves? That's the question, one of the questions. Yeah.
So I will say that if they have understood that what is the stage of their disease, I think it is not, they can ask that to relieve my suffering and not prolong my suffering, but euthanasia, which we don't, I think we will not be very, very, we will not promote euthanasia because as a palliative care physician, we promote comfortable life till the end. We don't promote prolong suffering, but we also not promote euthanasia. So euthanasia will not be the right term, but definitely they have full right that they should not go in ICU, they should not prolong their life, and they should be relieved with their suffering, with their, they should have the comfortable life till the end, but definitely not. I think euthanasia is killing somebody, and this, I think no doctor, no one will do this, but definitely they have a right that they should find a way to die with dignity till the end, with comfortable, with comfort, with pain-free and symptom-free life.
Yes, I think Dr. Mani, you had to interfere. Yeah, you had to.
You see, this is why we created that definitions, document. That we must not confuse put everything in the same basket. Euthanasia means active euthanasia, which is actually injecting a lethal dose or creating conditions for the patient to acquire a lethal dose in order for mercy killing. Now, this is not allowed in India, but there are many jurisdictions in the world which allow it under certain strict safeguards. Okay, it has to be firstly voluntary. It can't be, nobody else can decide euthanasia for you. It's also called medical assistance in death. Okay, MAID. So now this is not allowed in India. This is illegal in India. What is allowed in India is not putting somebody on life support when it is perceived to be futile or not beneficial, and stopping an ongoing intervention which is now perceived to be not going anywhere, okay, and not being beneficial. So this was termed erroneously as passive euthanasia, in contrast to what we said just now with active euthanasia. But passive euthanasia is an old and outdated term. Now, these are called withdrawal and withholding or foregoing of life support, FLS. So these sort of definitions, we have to come up to date so that we understand what we are talking about. Our courts have allowed withdrawal and withholding or passive euthanasia, which is now totally illegal. So you don't have to have apprehensions on what we are talking about in the appropriate not starting of an intervention or stopping an ongoing intervention, which is no longer beneficial.
This leads us to the question, Dr. Mani. There are many people, of course, are not very clear about what is the difference between withdrawal and withholding. And when we talk of ethics, between the two, which you think is more unethical? Is it withdrawing support?
Both are very ethical.
Withhold? Yeah.
Vasantaji, the issue is whether it's ethical or not ethical doesn't depend upon a withdrawal or withholding decision. Ethical or not ethical depends upon how that decision of not using an intervention is taken. Okay, so that is what the court has defined. You got to have a collegiate or multiple physicians have to take the decision together with the family, the centrality being the autonomy of the patient. So if you have got these elements, and that is accomplished through communication, an open communication, and this decision may evolve over a period of time. It may not be taken abruptly. It has got to be a thoughtful decision. Once this is established, that when you weigh the benefit versus harm, the harm outweighs benefit in any decision, in any intervention, and that is an ethically rooted decision. Okay, if you don't want to harm, because first law of ethics is, first of all, do no harm. Once you've taken this, whether it's withdrawal or withholding, they are equal in modern bioethics. They are also equal in the various societies in the world, consensus. Why? Because if you made withdrawal less, it's a more difficult decision, I agree. And maybe it needs more communication and more transparent documentation. However, if you were to separate the two, with withholding being allowed and withdrawal not being allowed, it would lead to many people under treatment and to many people over treatment. Why under treatment? There are some people who may have some significant chance of survival, and you deny them even a chance of a trial of intensive care. Why is it over treatment? Once you put somebody on an intervention and after a few days you realize you're going nowhere, you have no chance to go back and remove. So it is very clear, both are equal, and the court hasn't distinguished between the two anyway.
Anyway, this is linked to the scarcity of the life support systems. This is available in most of the places. And that's where the matter becomes more complicated about the withdrawal and withholding. Yeah. We are still not in a situation that it's freely available for the entire population. And that's what. There is a question which somebody has raised. Probably, Ms. Gupta, you might have had experience dealing with so many people that, somebody has written that I want to give an advance directive. But then under the present situation, it's so difficult to give the advance directive, get it informed to the High Court and the Higher Court and all those things. So do you have any experience of people who are able to give the advance directives while they are in a proper mental condition? They decide what is to be done when they reach the terminal stage.
Well, I think most of our patients actually don't have registered advanced directives. And you're right that it is a procedure that most people find is very clumsy. You have to go have some authority, district magistrate or whatever. You have to sign in their presence. You have to have witnesses who are also there and sign in his presence as well. And I think Dr. Rajmuni and others are trying to have that simplified too, so that it can be made easier. But I have seen worldwide, the advanced directive is really not used that much. And what we are doing is, we are actually, what I find very helpful, keep on having conversations with the patient, with the family, as to what they would want going forward, prepare them for it. And it cannot be done in one go. It's something that has to be done over time. The person there is here, let us not forget, they're going forward, there may be conditions that we didn't even anticipate would happen.
No.
That could happen. So therefore that has to be built in too. But I think on the whole, when we go certainly into the homes and the family, we get a sense of what this person wants. Slowly we move them in that direction, get an idea, and based on that, build consensus within the family. In India, it's very important to take the family with you, Yeah. So we build consensus within the family. This is what the person wants. At that time, this is what all of us must work to ensure. You heard that conversation where that girl said, I want this done. And the nurse explained to her that that time is over. What is needed now is what your mother wanted, which she said, don't let me go in pain. And that's our effort now.
Thank you, Dr. Gupta. Dr. Rajgopal, would you like to have the last word on this before we close the session? Dr. Rajmuni for this matter.
Yes, I think I totally agree with Dr. Ms. Sushma Gupta. For a few things that have to be remembered. Yes, the Supreme Court verdict of 2018 validates advanced directives. If I write down an order, if I write down my own advanced directive expressing a wish that I should not be subjected to CPR or artificial life support, that's binding. The only problem there is it requires to be countersigned according to the Supreme Court by a magistrate, which is impractical. But the most important thing is what Harmala said. It is not enough to write it down. It's important to discuss it with the family. Because whatever I have written down, I won't be able to claim my right, but my family will be heard. They have to be on the same page. Thank you.
Thank you. Dr. Mani, want to add anything more? You are muted, please.
Just briefly, I must say that the medical societies and some of the very premier institutions have got guidelines on withdrawal withholding. The Indian Society of Critical Care Medicine, Indian Association of Palliative Care, and both combined guidelines. All India Institute of Medical Sciences has got a wonderful document on an institution policy on end-of-life care. The Manipal group of hospitals has got the Blue Maple. So the physicians and caregivers among us should go through them, because that is the basis of even a court judgment, whether something is valid or not. There has to be a professional stand first. We should not be looking to the law first. We should be looking at our own best practice standards first, and practice according to best standards, which is rooted in humanity. So this is my appeal to my colleagues, and appeal to the public is, please ask your physicians the right questions, engage in proper conversation, not in superficial conversations. Raise your doubts so that we can, in a combined way, we can produce the best for the patient. That would also bridge the gap between the public and the physicians today.
Thank you so much, Dr. Mani. I think we had an excellent session today from all of you. Of course, there are many questions which are not very clear to the public at IHS. So even if they want to do advanced directive, what I think many of the things have been clarified today. I'm sure with the institutional policies existing at All India Institute and Manipal, we are now planning to see that can we have a national policy which is implementable by all institutions, whether they have a palliative care unit or there or not, but still they have to take a decision. So we have to come out with a policy which can be applicable to everybody. Of course, we'll start working on that. And thank you all very much. I'll now hand over to, and Dr. Oli has already posted both these ICMR documents in this chat box. It is there in the available network, the NCDR website also for others to go through that to understand what is it we have been talking all along the last 2.5 hours. I hand over to Dr. Oli and Shilpi to complete the session. Yes.
Thank you very much. Thank you, madam. Thank you all the speakers for this excellent session. I think it has been very, very useful to all of us. ICMR Bioethics Unit is really grateful for one and all for joining in today. I also thank all the audience who have joined us today. Dr. Muthuswamy for chairing the session, Dr. Rajgopal, Dr. Rajmuni for your wonderful talks, Dr. Sushma Bhatnagar for your wonderful speech, as well as Ms. Harmala for your emotional session that you took, for all these wonderful talks and presentations and sharing your enormous experiences. I also thank my back-end team here, my colleagues, Dr. Manikandan, Dr. Shilpi, who have worked hard along with the IT team to make this a success. And thanks to the director also for supporting our activities, along with other technical, admin, and finance staff from ICMR NCDIR. We will be very happy to receive your comments and further questions, if any, by email. Please feel free to write to us. We hope to be working in this area, and we'll be in touch. Thank you all very much.